Good afternoon, everybody, and welcome to the Digital Collaboration Solutions Readmissions Reduction Learning Series. Today, we're going to be speaking about readmissions penalty financial risk analysis with BCS's Mike Levinger and Tim Perkins. And without further ado, we'll hand the show over to Mike Levinger.
Thank you, Laura, and good afternoon, everyone. And we appreciate your time as we talk to you about readmissions penalty reduction. As an agenda this afternoon, we'd like to first give you a brief overview of digital collaboration solutions, and then secondly, talk about readmissions financial risks, what types there are, and some of the strategies and methods to reduce those risks. And then I'll turn it over to my partner, Tim Perkins, who will go in detail around analyzing a readmissions risk penalty and a case study of reducing that risk. Of course, we're happy to have any questions that you might have, and we'll finish up with questions and answers. Digital Collaboration Solutions is a consulting and services company that provides care coordination and patient-provider engagement solutions for organizations in healthcare. We take an integrated approach to helping you improve care coordination by recognizing that effective coordination of care is the result of the integration of processes, what your and other organizations are doing, enabled and put in place by the various people, both providers, administrative staff, as well as patients and their families, and the need to have great communications across all of the participants and all of the organizations providing care, and that technology can be an enabler and an impact to help improve your delivery of care coordination. But we also recognize that if you put technology in place without working on the other areas, you're likely not going to succeed. So our approach is to look across all of them and help provide an integrated answer to how you can improve care coordination and do better patient and provider engagement. When we look at readmissions, we see a number of financial risks. First, the CMS 30-day readmission penalty, which my partner Tim will look at in great detail in a few minutes. Secondly, care quality. There are a number of ways that readmissions reflects care quality problems, and those measurements of care quality can have a financial impact on your organization. Things like the Medicare Quality-Based Payment Reform Program, Meaningful Use CQM, or the PQRI program all can have an impact on your finances, and all can be impacted by 30-day readmission. Similarly, hospital-acquired conditions are also something that are indicative of readmissions issues and can have an impact on your hospital. Hospitals can be impacted negatively by readmissions on the revenue line. Under-reimbursed Medicaid and Medicare can bring down your revenue because oftentimes, and your profitability, because oftentimes you're going to find that people are getting readmitted and admitted who are getting Medicare and Medicaid payments, and those aren't equaling the costs that you have for an admission. And lastly, we can see a number of cost of delivery impacts. Medicaid spending per beneficiary is certainly being measured under the value-based purchasing program, and if you're getting lots of readmissions, that can have an impact on that. It can also drive down your hospital profitability, and things like uninsured admissions and ER visits land on the bad debt line of your hospital, and of course that has a financial impact as well. We see a number of regularly used proven strategies to reduce readmissions. Improving post-discharge appointment adherence, getting your patients back in a timely fashion post-discharge can have a major impact on reducing readmission. The right use and adherence to medication, both med reconciliation and med adherence, are critical to ensuring that your patients are getting healthier and not coming back post-discharge. And similarly, and more broadly, that you have good adherence to post-discharge care plans. For example, the addition of hip and knee replacements to the CMS penalty program means that post-discharge adherence to physical therapy can have an important impact on readmission. And lastly, you want to make sure you're managing transitions of care across the various organizations and settings delivering care to your patient. Your hospital will get impacted by readmissions regardless of where the patient's coming from when they're readmitted. In summary, you want to have a good comprehensive care coordination program in place. So what are the challenges to doing this? First, you have to identify which readmission risks are the ones that are impacting your organization, which are the biggest for you. And then based on that, identifying which strategies will be the most effective to help your organization. And from there, which deliver the biggest both financial and quality impact. Understanding those strategies, you now have to say, how are you going to fund them? And even with funding, you have to make sure you can effectively implement them. Frequently, care coordination strategies go across organizations, so you're going to have to work with those different organizations to show them the benefit and value for them, for you, and for patients of implementing various types of care coordination programs. Not easy, but if you do it right, you have a big impact both on care quality and on financials. DCS's approach is to look at that methodically, for each potential strategy to look at the risk today, understand and quantify that risk using either publicly available information or your own internal data. Then based on that, estimate the return on implementing the strategy. And once again, do that as quantifiably as you can, recognizing that there'll be other financial and quality improvements. Look at the cost to implement the strategy, and then you can project a return on investment that lets you say, is the return worth it to implement this particular strategy to address a risk? If you do that methodically across the various risks that you have for readmissions, you can decide the right things to do and make sure that they're having a positive impact on your patients, your organization, and other organizations. So to look at that in more detail, I'll turn it over to my partner, Tim Perkins, who will review how we can help you estimate readmissions penalty risk and go through a case study of how a hospital addressed those risks. So take it away, Tim.
Good afternoon, everybody. We're going to run through a quick example of this strategy and how it works and how it breaks down. So let's take a look at the readmissions penalty, what we can do about it, the type of impact we can have, and we're going to take the similar approach Mike just discussed. First, we're going to quantify the risk of 30-day readmission. How much is it costing you today in your organization? We're going to use publicly available information, and we can get pretty close with that. And then we're going to estimate the return on implementing the strategy, in this case, improved appointment adherence. What is the impact that it can have on your organization? And what is the impact that that change will have on reducing your 30-day readmission penalty, and therefore what kind of revenue we're going to be able to recoup. Estimate the cost to implement the program, to implement that change, and then we can compute a straightforward projected on the financial side. We can also do some work on the quality return as well. And then, is it worth it? And, can it be funded by improved cash flow? Can it be funded in other ways? We know that cash is always tight. So how does it get funded, and where does the money come from? First, a little bit of background on 30-day readmission penalty. I assume most people listen to that this are familiar, but real quick, right now it's up to a 3% penalty on all net Medicare payments made to the hospital. So in every dollar they're going to reimburse you, they could reimburse you as little as 97 cents on the dollar. That penalty amount is adjusted yearly, and it is adjusted on your individual experience and claims, Medicare claims, and is based on your past 3 years of Medicare claims. So every July 1st, the new data set gets closed up, and then they do their calculations for the next coming fiscal year, which starts in October. So they take, right now, we are tracking heart attacks, AMIs, chronic heart failure, pneumonia, COPD, total hip and knee replacements, and the rumor is that for fiscal year 2016, they're going to be adding bypass. They take these DRGs, these incidents in the hospital, and then they use that claims data on 30-day readmissions to approximate, or as a proxy for the quality of the care, and then calculate their penalty. So it's a pretty complicated formula. It's based on risk-adjusted excess readmission ratios when you compare you to other hospitals, and it's a very complicated formula. Let's take a look and let's quantify the impact of the readmission penalty risk. This is for a hospital, undisclosed hospital that we were dealing with recently. They have $2.7 billion in gross patient revenue, gross patient charges, 600 beds, 32,000 discharges. That shouldn't be a dollar sign. That's number of discharges. 10,000 Medicare patients, so about a third or so of their business is Medicare. Their average charges is just under $66,000 for Medicare. So the total Medicare charges out of the $2.7 billion, they're doing about $675 million worth of Medicare business charges. They're a large urban hospital. They are fairly high disproportionate share. In other words, inner city, low income population. Their current readmissions factor is 0.9807, which means that they're paying almost a 2% penalty for 30-day readmissions. out of the possible three. They have an operating costs to cover charges. In other words, there's 25.6% or 0.256 is what their charges are for their costs, excuse me. So for every dollar of Medicare that they deliver in charges, it costs them 25.6 cents. So when you take the Medicare and the capital and the operations together, basically it costs $184 million in Medicare costs to deliver $675 million in Medicare charges. Of course, Medicare does not pay on charges. They pay on a percentage basis. And in this case, for this hospital, the amount of reimbursement for the $675 million in charges is about $185 million, $184,550. So they're getting reimbursed at about 27 cents on the dollar for their Medicare. So long story short, they are getting paid by the government $184 million a year to deliver $675 million of Medicare. So when we multiply that times the readmission adjustment factor of 0.9807, basically their penalty, their 30-day readmissions penalty is $3.5 million a year. All this is publicly available information that we pulled together. So $3.5 million is the penalty on a yearly basis this hospital is paying. That's the impact and cost today of the penalty risk. When we look at, okay, so if we make changes, what's the impact of those changes? We look at some studies that were done. You may be familiar with Project Red and Project Boost and reengineering discharge and post-discharge best practices. There was one study by the American Heart Association, large-scale study, 30,000 patients, 225 hospitals, which shows very simply that if you can do your follow-up with a patient within 1 week, that you will experience a 2.8% decrease in 30-day readmissions. It's the closest, clearest, biggest, most statistically correct study we can find that says get back early and you will experience a 2.8% decrease in 30-day readmissions. So very simply, we say if we can achieve that kind of appointment adherence, we should also be able to achieve a 2.8% decrease in 30-day readmissions. And this was specifically for heart failure hospitalizations, for CHF. So what we will do is look at peer analysis of hospitals, just like the one in the study. And then we will say, okay, what's the impact if we can decrease your CHF readmissions by 2.8%. So we use peer analysis. And the reason we use peer analysis is that we're not trying to recreate CMS's model, which they themselves say, do not try this. There's too many variables that they control, too much information that they hold close to the vest on the claims information. One of them, for example, 20% of patients don't come back to the same hospital. So there's a lot of information where CMS says, don't do this. So we're using pure analysis to approximate. I'll show you how that works. We go through the list of 3,500 hospitals that participate in the IPPS program, the inpatient program, and we look for, in this case, this hospital's in Region 2, so that cuts it down to 381 hospitals from 3,500. They are a large urban hospital, so there's 224 within Region 2. They are a teaching hospital with a resident ratio between 0.6 and 0.76. And then they're a relatively large hospital with between 330 and 685 beds. We're able to whittle that down to about a dozen peers in their geographical area that look like them. And this is specifically, these are the hospitals that look like our undisclosed hospital. So New York, Northeast area. We take out the 2, 4, 5 on the bottom because we cannot compare hip and knee procedures because they had too few to do it. You need at least 25. So we take those out. So now we have who's left. We take these hospitals and we look at the readmissions adjustment factor, and we also look at the results off the hospital compare website that says, where do you stand against the averages? So the average for heart attack is 18.3, 23% for CHF, etc. And you can see where each one of these hospitals stacks up against the averages. We do some math here where we take the sum of the variance from U.S. averages, and then we're able to leverage and average that across for each hospital to kind of come up with a rating from top to bottom. You can see that here where Malmedese is at the top, 1.3 off the some of the U.S. average. We then apply our theoretical where we say, okay, what if we can get CHF from where it was at 23.7 down 2.8% to 20.9? What's that impact going to mean? And in this case, we're not changing any of the other averages, although we know they'll have a positive impact on readmissions as well. The study just said CHF, so we're going to use something we can statistically use here. So that would bring their variant down to 5.5. And so now what impact does that make on the number? Well, basically it changes it from about a 9807 to a 9941. So that's a pretty good jump. So now we've got a new readmissions factor, and that's based on the peer group. So if we take that readmissions factor, and now we go back, and given the same volume, and giving a cost of what it takes to implement a program like this, we're able to do a return on investment. So the impact of improving the readmissions penalty by 1.34% is fairly sizable. Program costs along the top, and if you look at benefit and cost, so for about a $350,000 investment over 3 years, we're seeing about a $5 million revenue come back. So it's netting out $4.6 million to the good in terms of recovered revenue. If we chart it, it looks like this. At 100% achievement, 2.8% improvement in CHF, we're able to deliver about $4.5 million of savings to the organization over a 3-year period. And then we also look at it at 75% as well to say even if we only do 75%, we're still delivering a $3.23 million savings to the organization. The penalty, the ROI, we do the impact. We looked at the cost to implement change. We look at the net impact of what the change brings to the equation, and we're able to do an ROI. In this case, it works out well, and there's a solid return on investment back to the organization. Mike, would you like to sum up?
Thank you, Tim. That was a great presentation on the details of reducing readmission risk. And to come back, as we said earlier, we highlighted one risk today, the CMS readmission penalty, and how you can better understand it and how, as a case study, you might be able to impact it. As we talked about, there are a range of other readmission financial risks which, using the sorts of strategies we described, you can methodically review and understand and then have impact on. So what do we recommend? We recommend, in summary, first, identify the risk components that impact and apply to your organization. And secondly, identify the strategies that make sense for your organization to address those risks. Then do a financial analysis for each strategy to understand its impact on readmissions and on those various types of financial risks, estimating things like the CMS readmission risk penalty, recognizing limitations of that analysis as Tim described, and understanding the costs of the various strategies you put in place and of a comprehensive integrated readmission management program. Then you can compute your ROI and understand financially what makes sense for your organization to reduce readmissions. Now keep in mind that even if the financial risk is low, reducing readmissions is good. It improves patients' health, it improves quality and other scores, it improves things like your patient satisfaction scores, and overall shows that you're doing a better way of helping your patients be healthy and managing your hospital from both a care quality and a financial risk point of view. Well, we thank you for your time this afternoon. It's been great to give you some understanding of reducing readmissions financial risks, and we look forward to talking to you again in the future. Thank you.